To get organised, I'm just going to re-scrub. Okay. So we're just getting started here. I'm Dr. James Simcock, and we are about to do a total ear canal ablation and lateral bulla ostectomy in a small dog. And this dog has got some middle ear disease. It's got a soft tissue swelling / fluid in the tympanic bulla, and so it's got clinical signs associated with that, irritated by its ear and scratching at its face. And so we've elected to do a total ear canal ablation today. So as you guys know, probably just getting people tuning in now, if someone can just type in the comments to let me know that you can hear me okay and that you can see everything okay, and then we'll get started. I'm just waiting for my hands to dry. I've just used alcohol rub on them for my scrub, so it'll just be a couple more minutes while they dry out. Otherwise it's near impossible to get my gloves on. So we've got a laminectomy drill. Oh, easy, good job. What size burr you got on that, Ewan? 3, yeah, that'll do. So again, we just, if anyone is out there watching our live stream with this TECA, if they can just put a comment in the comment section, just let me know that you can see and hear everything okay for me, that'd be great. Perfect. Welcome, guys. So, thank you for joining us. We've got a little dog here we're about to do a total ear canal ablation on, and getting set up, just waiting for my hands to dry. I'm going to put some gloves on. Got everything draped in already, which is excellent. So as everyone at the clinic here knows, Southpaws are probably, at Southpaws, TECAs are probably my least favourite surgery to do. Still do a reasonably good number of them, but I just don't enjoy them as much as pretty much every other surgery that we do. So we'll go through, I'll give you a few tips and tricks as we go through how I like to do them and what we're trying to achieve. Can I, Carly, can you just do my gown up, please? So, if you guys are unaware, we have started a new membership area on our YouTube channel, and that membership area is a monthly fee, and it gives you better access to the videos that we do. So the live stream surgeries, when we do them live, they will be free, but once we finish the surgery, they move over into our paid content area. And the other thing that we put on our membership area is a whole bunch of short stories and videos just looking at kind of x-rays, CT scans, lameness examinations, kind of interesting things around the hospital, with a goal to try and give you a bit more of an insight into what we have going on at the clinic, and also to give you some tips and tricks and things like that you can kind of use in your practice. So if you guys have any kind of feedback on how that's going or things you want to see, let me know. If you have any questions about how that works, certainly jump on and let me know. So, Piyush, nice to see you.
What are we doing here? Sorry,
yeah, so Piyush, we're doing a total ear canal ablation in a little dog, Maltese cross, who is about 10 and has got middle ear disease and a tympanic bulla full of soft tissue and some destruction of the bulla. We did a CT scan on it. This is actually another one of the surgeon's cases that I'm just operating on today. So he'd previously done a CT scan, and there's kind of an expansile lesion in the bulla. And I guess there's some question about whether the underlying process is benign or malignant. And can I just try and see? I just want to make sure I'm not getting my head in the way. Go that way a little bit. So that's pretty good. And if you're watching, just let me know if my head gets in the way. I have a big head, as it's been pointed out on YouTube before, and sometimes it gets in the way. So Carly, you're all good at the front end. Is he on fence there already? Cool. How many mics? 6, perfect. So keep an eye on that. If we need to go up to 10, I don't have any problem with that at all. So I'm going to get one of you guys to try and just literally turn his ear inside out here if we can. So the approach here is really to try and get around the vertical ear canal. I'm just going to clean some of the wax and gunk out of here. This amazes me, even when we prep these guys, how much crud and stuff there is in the ear canals. Okay. So it's a fairly straightforward approach. I generally just go around the base of the ear, through the cartilage here and the outside, and we follow the ear canal down, down the vertical ear canal to the horizontal ear canal, and then we kind of make our way to the bulla. So we'll go ahead and get started. And Carly, if you can keep half an eye on the questions there, if there's any questions, just let me know. And likewise, Jeff, Yuri, sorry. I've been calling you and Jeff all day today.
I thought that was on purpose.
We have another guest with us who is one of the surgeons from Melbourne Uni. Hannah?
I thought you forgot my name for a second.
Doing the classic deflection. I was like, does Hannah want to be introduced or not?
Totally fine.
So we've got the full team here. So I normally make the first incision with scalpel blade, and then I use cautery electrosurgery to kind of follow up. So as I move around here, and I just try and kind of move, so just come back here and try and flip that bit out a bit more. It's always hard to get this first bit done. Once we're through this bit, it gets a lot easier. And if you want to just keep a bit of an eye on whether there's any questions there as well. Yep. So I hope everyone's having a nice week in this lead up to Christmas and the holiday season. We've been pretty busy here at South Paws. I feel like it's been a mad rush and Christmas has come around really, really fast this time. So I'm just right at the top of the ear canal here, and I'm just really trying to get right down onto the cartilage, and then as we kind of chase things down, what we got there? I'm going to get actually. Can I get some more towel clamps? Do we have any more towel clamps? There we go. So towel clamps are actually a really nice kind of retractor, and these actually are what I would consider an atraumatic forcep, even though they have a big ugly point on them. But we can basically put that in there as a handle, and we don't have to keep grabbing onto things, and I think they hold onto tissue really well. So when you're doing things like axial pattern flaps or surgeries where you need to kind of move tissue and manipulate it quite a lot and repeatedly, I think the towel clamps can be a really great option for doing that. And have you got any Gelpies on the table there? Let's get this way. So as we're kind of moving around, Hannah, just
keep moving within.
yeah, just keep following me down kind of thing. We just kind of go around bit by bit by bit. Okay. Some Gelpies in here. Yeah, we'll twist it all up. So I need to be a bit careful with our Gelpies. I'm happy to put them in here kind of fairly superficial, but as we get a bit further down, especially around the facial nerve, I really try and avoid putting them in too deep. So Hannah's got the hard job here of trying to keep everything so I can see it. We're giving you your break today. He's running the table. You can have a rest. So there's lots of hand gestures in this surgery. And Hannah has to guess where I'm going next.
Just go clockwise. No, okay.
No, I can't just keep it simple. So I'm getting down into the region of where there's the junction of the vertical and horizontal canal. Let's go that way. And this is where I'm going to be really careful to stay right on this cartilage. Just sing out, guys. I'm leaning over here a bit, so if I do have my head in the way, just certainly feel free to sing out. This one,
James, a question's been asked, can we use the ear pinner auricular cartilage for repair of oronasal fistula defects?
the ear pinner cartilage for repair of oronasal fistula defects. Can that be done? I think it can be done. I've never done that myself. I think it actually is reported somewhere though. You might actually know better than me if you've seen that reported.
I've seen that work too.
You have or haven't?
No.
No.
Usually
So-
just like skin flaps.
Yeah. I think it can be done, and I'm sure there's a case report or case series of something like that having been done, but I can't think specifically of that right now. I think that would be one of my last resorts if I was looking at options for trying to fix those oronasal defects. Sometimes, and again, I haven't ever got to the point of having to do it, but you can get these like silicone plugs that you can literally just put in there and they effectively just block all the material getting from the mouth into the nose, and they can work really well. But typically we'll try a primary repair, and if that fails we'll try and do some kind of skin flap and bring some new tissue into the, so I'm going to go that way, into the defect. So we're getting down into the kind of region where I might have facial nerve. I'm just going to reposition that because the chance that we've picked him up there. And the reason I really don't love these surgeries is you're kind of working down this deep dark hole. What's it on? Yeah, can I get it down to 20 please? And I feel like it's just hard to see, and there's really not a great way, and I think I've ever seen that really helps with the exposure. In any meaningful kind of way. And the other instrument I've got down here to try and help with my retraction is a freer. And I'm just kind of using that to help pull the tissues out of the way as we come down the canal here. Just go that way a little bit. And as Hannah's pulling on this ear canal, and she's doing a very good job, you can see these little cords of tissue that kind of become tight, and they're the areas that we need to kind of come through to free everything up. I'll actually come this way. Yeah, I've got this one here. And you're getting down now, you can kind of feel fairly solid bone underneath, so I know we're getting down pretty close to the skull. Oops. So this is the other thing that happens, is there's a couple of fairly decent blood vessels in there that, as we're doing this, we can upset them. Let's go caudally there, Hannah. Just go caudal. I think they're actually in there can penetrate into the Bulla there a little bit as well. Can I get some gel foam, please? So if you imagine we've got the canal coming down, it's basically attaching onto the Bulla, and there's a blood vessel at the front here to branch off the carotid artery, and as we are cutting down, there's really not a lot of space, so I've just nicked the side of it. And it's bleeding a little bit. I'm not worried about it at all. It's just kind of welling up in the bottom of my hole, and I can't see anything, so it's a bit annoying, but generally a little bit of pressure here and some time will improve things. We're going to put a bit of gel foam in here as well. Sorry, you'll get a bigger piece. I'll take the whole thing out. So we'll put this in here and see if we can't get this to slow down with the bleeding. It's already slowed down a little bit. I'll just upset it with my freer. So this is where I always time the 5 minutes that I want to wait, and then I wait about 35 seconds and then keep going.
Yeah, sounds about right.
Yeah, very patient as a surgeon. So Hannah?
Probably my time further down, so I have more traction. I feel like
No, I think it's okay there. So Hannah's joining us from Melbourne University. She's in a residency program there, and she spent 2 weeks with us. 1 week, 2 weeks?
1 week.
1 week. And she's originally from England and is enjoying living in Australia and spending time by the beach.
Sure am. I'd rather it be more, slightly warmer summer.
Yeah, I know.
This year.
That's Melbourne for you.
I picked the wrong city.
Yeah, exactly. Especially, I guess, how long have you, since you've been here, has it just been purely COVID?
No, I've been here 8 years.
Okay, right.
But the last 3 summers have sucked.
Yeah, I agree, 100%. For anyone that knows me, I like to spend a lot of time out on the water fishing or diving or doing those kind of things, and can definitely attest to the fact that the weather has been average the last couple of years over summer. So I'm just extending down. I'm being a bit more careful now, having I've made this bleed once already. I'm just using this kind of blunt dissection to help kind of get underneath. And you can kind of make out here, I don't know if you can appreciate it on the video, but there's this kind of soft tissue stuff just kind of coming out here in the canal. And we're just going to get all the way around that. So just very carefully going around and around. And this is definitely a surgery. We talk a lot about surgery, kind of the key to good surgery is getting on the plane of dissection that you want. And this is one where you definitely want to be on the right plane to get a good exposure and minimise hitting all the important kind of things. And I think that is facial nerve running around here, this white thing. So I'm being careful not to pull on that too much and being careful with my gelpies and things, make sure I don't compromise that at all. Yui, can you hold on to this for me? So I'm getting to the point where I'm going to have to just amputate this canal. Come this way. Sorry, towards me, yeah. I think I'm pretty much just going to take it off. I'll try and get this gelpy in a slightly different location. Oh, so for those of you that have been kind of keeping track, and I did get a bit of a video of him walking around today, I did surgery on a 3-legged dog named Pogo who had a front leg amputation when he was a puppy and then developed an angular change in the leg, and I'm going to do a kind of follow-up series on him, I think, a little video just with the x-rays, the post-op x-rays. He came in for his 1-week recheck today and he's doing awesome. He's using the leg pretty well. He's still tires quickly and pretty ginger on it, but he's doing really, really well. The owners are really, really happy. So I was very happy to see that this morning.
When you do this amputation, James, do you always do it from dorsal to ventral? Is there a reason why?
Yeah, do I always do the amputation dorsal to ventral, and is there a reason why? I normally do, if I'm honest, because the bone is a bit more superficial. I can feel bone right here, and then it kind of comes down. It's a bit hard to see and feel it distally. And I'm kind of just going through it carefully. I might have just had my head in the way. So I was getting too excited. Big head getting in the way. Okay, so we've got the ear canal out. I'm going to chuck this in, we're going to get a culture and we're going to chuck it in for histo as well. So just pop this over here for a second. And some of this goop in here, I want to try and get out for histo as well. Have we got a big curette, please? So, how well can you guys see down that hole? You just move your hand out of the way. Can you see on the screen there when I'm shining my light on there? Can you guys see down there at all on that screen over there?
Yeah, to an extent. This part quarterly is
Okay. So just try and get a better view in there. Let's try and get another instrument. So
Yeah.
what we're looking at down here, we've got the facial nerve, which will be running around the back. So I think this white guy here is the facial nerve. Comes out right behind where the bulla is. So it's very, very close to the operating field. And then we've got this kind of space here. So that's all bone around the top. Bone, bone, bone. And then we've got the bulla at the bottom. So all this stuff here is all abnormal tissue. I think it just looks like benign kind of disease. Probably the smaller of those two, please, Kelly. But we're going to take some samples and just make sure it's not a tumour or something like that. If it was a tumour, there's really kind of not a lot of other great options from a surgical standpoint that we'd be able to do anything about, which would be meaningful. So I've just got a fairly large curette. I'm using this larger curette because I want to just get some samples. And can I have a culture swab too, please? So you can see all that purulent kind of goop in there. The pus lovers will love this one. So it kind of looks like one of these cholesteatoma type things where they're just these expansile, I don't really think we understand why exactly they happen, but it's this chronic inflammation. It causes destruction of the bone, I guess, and causes more problems. I'm not aware. Is there any other kind of ideas?
Of course, your turn.
Yeah, got two residents here. They're probably smarter than me with the literature. So you can see that kind of purulent stuff and this kind of caseous material in there. So pretty confident that that's going to be most likely... I've lost my train of thought. Most likely benign disease rather than a neoplastic problem. So here you need to avoid the temptation to get your Gelpers in really deep, I think, and traumatise this facial nerve. So I'm going to kind of use just some manual retraction. We're going to get some rongeurs in here and we're going to start to take away some of these kind of walls of this bulla. So I've got a neuro kit and I've got the world's biggest rongeurs and I've got the world's smallest rongeurs. So we'll see how we go. They're too big. I'll use these little guys. Don't tell Charles I do this with these little guys because I might break them. So I'm just carefully coming around and taking out kind of the soft tissue, like the very distal aspect of, I guess, the horizontal canal as it attaches onto the bulla. So I'm getting down to kind of bone all the way around. That's perfect, Ewan. And then what some people do, they'll use the the rongeurs to kind of break down the bone ventrally and laterally, and it's actually coming away pretty well. Sometimes I do use a laminectomy drill, which I have right next to me, but this is all coming out pretty well so far. I'm going to jinx it by probably making something bleed in just a second. That's pretty good. And the bone is really wafer thin in this dog because it's had this kind of expansile kind of lesion causing problems in there. Oh wow, this is actually kind of satisfying. There's a whole bunch of goop and crap in there.
Yeah, I was going to say.
Yeah, we'll get some histo. So you can see here, actually, Hannah's pointed out, we've got the whole lining of the canal, the bulla, and then we've got the kind of caseous crud on the outside. I'll leave that to Yuri over here. And the key with this surgery is getting all of that lining out. If you don't get it all out, it's secretory epithelium, and so if you leave too much of it behind, well, that's really satisfying. You see that kind of all peel out. And this is what you want to happen. So occasionally just see a little tag of it in there, and you can grab a corner and it just all lifts up and comes away. So that's a good example of that. But you want to get all those bits of rubbish out of there. And the kind of instruments we use for our neurosurgery is really helpful for this. We have a, they're obviously quite delicate. Do we have the pick there somewhere, Yuri? I've got my loops on so I can't tell. We might be able to use this guy. So I've got my loops on, which are giving me magnification, and I'm just again coming around. Oh yeah, That's the stuff. Wow.
This little dog's got quite a lot of stuff in it.
I know.
Poor thing.
Okay.
You don't add any more fingers to?
No, I don't think so. So for normally not liking TECAs, I'm quite enjoying this one. So I'm just kind of scraping away, getting the rest of this lining out. And it will be hard to see, but I'm looking down inside the Bulla now and it just looks like this really smooth surface.
I think we'll be alright without it, thank you. Anywhere, James, that you want to avoid scraping too vigorously?
That's a great question, Ewan.
It's not a leading question at all.
So Ewan just asked the question, is there anywhere we want to avoid scraping too aggressively? And the answer to that is yes. So we want to get all the stuff out from kind of ventral, directly medial, and then I'm going to make something bleed here. The area that we want to avoid is kind of dorsal and medial. And that's where the vestibular apparatus is going to sit, so we don't want to mess with that too much for obvious reasons. So I'm going to get some flushing there. Oops. Are there any questions there, Yui?
Where is the facial nerve?
Where's the facial nerve? So I'll show you the facial nerve in just a second. I just want to, we've got a pretty good window here for kind of seeing what's going on. So I just want to get all this stuff out while we're doing it. But for Yui and Hannah, you can see it really nicely in there now. You've got just that nice shiny bone.
This is probably the clearest TECA
I was about to say, I think this is, I don't know, you take more bone around it than you would usually, or because that just seems like I can see directly into it.
Yeah, I do. Look, and this is why I feel like I always hate them, because I feel like you can never just really see that well. So I do judiciously kind of take the bone from around the outside to get a better window and be able to see.
But you're much less likely to leave anything behind when you can see that nicely.
Yeah,
so.
exactly. So the only thing I can't really see is just what's going on up dorsally and medially, which is where the vestibular apparatus is anyway. Just the way that all came out, that lining, because it's beak disease and thick, and it's all just peeled out in kind of three really big chunks, which has been quite satisfying.
It's a great image of that retroauricular vessel there.
Oh yeah, so Yui's pointing out the retroauricular vessel. While we're looking at that, Yui, so you can see the proximity of things here. So you've got this vessel here, which is probably the retroauricular vein, I think it is. You're going to have an artery at the front, branch of the carotid, which comes up in that area, and then around the back. So the question about the facial nerve, I don't know how well that will come out on the screen, but it's basically running right around here. So that's this structure here. So I am
I think that's the fastest TECA I've ever seen.
not unhappy with that. I kind of gave it a big build-up, hating him. This has been more pleasant than most, let's say. There's normally more swearing. So I'm kind of digging around, just making sure I've got all this secretory lining. I can feel the extents cranially, medially and caudally. I can see all the bone there, taking all the stuff off ventrally and laterally. And yeah, I think we're good to knock out the next one. So I'm actually going to finish up there. We'll give it one more good flush, Yui. Sorry, that's what you're about to do for me. And the other thing sometimes when you're suctioning down here, if there are any loose kind of fronds of lining, when you're suctioning down there, sometimes they'll get kind of half stuck in the suction tip. and they'll make this really obnoxious whistling noise, and so you know that there's something loose down there that you still have to get out. So the fact that that's another trick, I'm kind of suctioning down, I can't hear that really annoying, like really high-pitched squeal. So I know that we've probably got all those loose kind of strands of stuff out. So I'm going to finish up there. We're going to chuck that swab before we use it to to clean everything up, and then Yui's going to close this for me. Closure for these guys, we might even get a little bit of local anaesthetic in there, Yui.
Yep.
And then I'll just show the guys what we're going to close, because I'll probably stop the live stream at this point as well. But we are basically just going to come up superficial and essentially just close the superficial tissues up here, generally in a couple of layers, and then I normally just kind of close it in a simple straight line.
With normally externals in these, are you happy with that?
Yeah, normally external sutures for sure. All right. Well, if you guys have any questions, I'm just going to deglove and keep an eye on things. So no more questions have come up. So I think I'll see you guys and communicate with you all next week. But if anyone is here that I don't come across, really hope you guys have a great Christmas and festive season, and hopefully get some time off to kind of reflect on everything that's happened through the year. We've got to find the positives where we can. It has been a pretty tough year for everyone. So, yeah, I hope everyone has a good time, and we'll see you all soon.